Assalamu alaikum. I am Dr. Muhammad Imtiaz. Currently, I am working as an assistant professor of oral and maxillofacial surgery. Today, I am going to discuss local anesthesia in dental practice. This presentation is part of an online course in which students are going to learn about local anesthesia, but our primary emphasis is on Vendor techniques. This presentation contains a brief overview how local anesthesia works. Then we will discuss pharmacology of local anesthesia, preparation for local anesthesia, and finally we are going to discuss the mandibular anesthesia techniques. You are requested to consult the educational material given in the various sections. Dental pain is one of the most severe pain that can occur in the human body. The use of local anesthesia has changed the dentistry. Before discussing local anesthesia, we are going to talk about pain. Pain sensation results from the noxious stimulus, then an action potential is generated and propagated, and pain sensation travels through the first order neuron to trigeminal ganglia, and the fibers originating from ganglia will travel to the thalamus. Finally, the pain sensation will reach the sensory cortex where it is perceived, and various neural connection will result in various kind of physical pains and the emotion. Now we are going to talk about nerve conduction. Generally, larger the nerve fiber, faster the nerve conduction, and greater the myelination, faster the nerve conduction, and smaller the nerve fiber, faster the anesthetization. Local anesthesia cartridge contains local anesthetics, which is usually lignocaine. Along with local anesthetic contains the vasoconstrictor. Epinephrine is present in various concentrations. Epinephrine is quickly oxidized, so sodium metabisulfite is added as preservative. The other contents are fungicide and carrier solution, which act as solvent. L agent. Now we are going to talk about L agents, what is the mechanism of action, and what are the pharmacological characteristics of the local anesthetics. Now we are going to discuss the mechanism. The primary aim is to produce the blockage of sodium channel, and it will lead to either prevention of the polarization or prevent the propagation of nerve stimulus. This diagram shows the ion channels. So ionized anesthetic bind to the sodium channels. Sodium entry is blocked into these channels. Sodium channel blockade prevent propagation of action potential. Lack of propagation block the sensation as signal is not transmitted to the brain. On the right, this is the diagrammatic representation, that is, the local anesthetic has been bound to the sodium channel. Now these have been blocked, and so this action potential is not going to travel further. In this diagram, you can see that action potential is traveling, and here it is going a little further. Now when it comes across the local anesthetic solution, which is shown in the blue color, the propagation of action potential will stop, and hereby the sensations of our sensation are stopped here. The chemical structure of the local anesthetic has three parts. The first one is the hydrophobic part. Second is the intermediate linking chain, which is either amide or ester, and this is going to define the type of local anesthetics. And third is the hydrophilic part. Now this is the classification of local anesthetics. They have been divided into two groups, the amides and the esters. The amide group is most commonly used, that contain articaine. The articaines are present are marketed in the form of 4% articaine. Piperacine is usually not used in the oral cavity, and it has a long duration of action. Then comes lidocaine. This is the most common local anesthetic. Then the mepivacaine. Mepivacaine is a local anesthetic which can be used without epinephrine, and it has the same depth of anesthesia as of lignocaine, and that lasts for 20 minutes. Prilocaine is not commonly used. On the other hand, there are the esters, the benzocaine and the cocaine and the procaine. The benzocaine has some severe side effects. Cocaine is used as a topical anesthetic in ophthalmological surgery. Procaine is just the standard against which other local anesthetic are set. The onset of local anesthetic action is dependent upon the diffusion to the site. More readily diffused to the site, and it will produce greater depth of anesthesia than the nerve morphology if it is myelinated or not myelinated. As we increase the concentration, the depth of anesthesia we increase the lipid solubility, the depth of local anesthesia increase, and then the pH of the tissue and the pKa value of the agents. This thing become very important when you repeat the local anesthesia. Now we are going to discuss the vasoconstrictor. The indication. Now we are going to discuss the indication of vasoconstrictor. The vasoconstrictor, the local anesthetic usually cause vasodilation. So by adding the vasoconstrictor, we are going to increase the depth of anesthesia. We are going to increase the duration of anesthesia, and we are going to reduce the systemic toxicity associated with the local anesthesia. And then finally, during surgery, the hemostasis can be improved by addition of epinephrine, and to produce this action we have to wait for at least 7 minutes. The vasoconstrictor agents are present in various concentration in local anesthetic solution. The most common is 1 in 100,000, but in some countries 1 in 50,000 is also available. But they are going to produce serious side effects in cardiac patients. In those patients, 1 in 200,000 is usually preferred, and this will decrease the amount of epinephrine that will enter into the bloodstream. The second vasoconstrictor is the levonorepinephrine. This is not usually available in Pakistan, and the vasoconstriction results from the action of epinephrine. Now we are going to talk about the epinephrine concentration in dilute solution. 1 in 100,000 mean 1 mg per ml, or 1 gram in 1 liter. 1 in 10,000 mean 0.1 mg per ml. 1 in 50,000 mean 0.02 mg per ml. 1 in 80,000 mean 1.0125 mg per 1 ml. 1 in 100,000 mean 1.01 mg per ml. 1 in 200,000 means 0.05 mg per ml. Now the vasoconstrictors, it stimulates the beta receptors in the heart to increase the heart rate strength, increase the strength of contraction and the myocardial oxygen consumption, whereas the beta 2 stimulation vasodilate the blood vessels in skeletal muscles. This can lead to the potential interaction between beta blockers, but it is just of theoretical concern. With the use of epinephrine, certain precautions are required for some patients, like the people on non-selective beta blockers, just as propranolol, tricyclic antidepressant, for levonorepinephrine and halothane and cocaine, which is going to produce as sympathetic response. The patient with significant cardiovascular disease such as ischemic heart disease and the myocardial infarction, and most importantly the hypothyroidism patient. They are not the absolute contraindication. We can carry out one extraction in these patients, but before starting we should check the vitals, and then we should see what is the current heart rate. If it is more than 140, it's probably not good to carry out the instructions, and this increase the chance of thyroid storm or the cardiac arrhythmias. So in patients which are prone to the side effects produced by epinephrine, what we should do? We should monitor the blood pressure and heart rate preoperatively, minimize the dose of epinephrine, and we can repeat it after 40 minutes, but total dose should be reduced. Monitor the blood pressure and heart rate 5 minutes post injections. Consider limiting the epinephrine to 0.04 mg. This is equal to 2 cartridges. Avoid 1 in 50,000 epinephrine solution, because this is going to generate also induce the production of endogenous epinephrine. And finally, the most important thing is that avoid the epinephrine impregnated retraction. Now we are going to talk about the PAS transformation and elimination of the local anesthetics. Amides are metabolized in the liver. The esters are metabolized by the plasma cholestasis. Biotransformation is not a major factor in the clinical application, except in the patient with severe liver dysfunction. Reduce the total dose of local anesthetic. Treat 1 quadrant per requirement if possible. Now we are going to discuss the recommended maximum doses of local anesthetic. Artican 4% with epinephrine is 7. The maximum dose is 7 mg per kg in adults, and up to 500 mg can be given, and 5 mg per kg in children. Maximum 7 cartridges can be given. Bupivacaine is usually not used in the oral cavity, and it's and great caution should be exercised in dental patients. Although the 0.5 mg or 10 mg 0.5 mg 10 cartridges can be used. The most important for us is the lignocaine 2% with epinephrine. The maximum recommended dose is 7 mg per kg, and up to 500 mg can be given, and maximum number of the cartridges are 30. The bupivacaine 2% with levonorepinephrine, the 11 cartridges can be given. Bupivacaine 3% plain, 6.6 mg is the maximum dose, and 7 cartridges can be given, and this is especially important in the child patients. The toxicity can be produced by the systemic absorption of an excessive amount of drug. Higher blood level of drug may be secondary to repeated injection, or could be a result of single intravascular administration. And this risk is one reason why aspiration prior to every injection is so important. And usually the aspiration 2 planes are recommended. The likelihood of toxicity depend upon the factors such as the site of administration, speed of administration, and the presence of vasoconstrictor. Now we are going to discuss the dose calculation. The percent solution represents the gram per 100 ml of the solution. Move the decimal place to the right, and this value will become mg per ml. Lidocaine 2% is equal to 20 mg per ml. Most cartridges are 1.8 ml. Therefore, 1 cartridge of 2% lignocaine contain 1.8 ml into 20 mg is equal to 36 mg of lignocaine in a single cartridge. For example, a patient is of 20 kg. 7 mg per kg is into 20 kg is equal to 140 mg. 2% lignocaine is 20 mg per ml, and 140 mg divided by 20 mg per ml is 7 ml can be given, and for each cartridge is equal to 1.8 ml. Therefore, the maximum dose is 7 ml per 1.8 ml. Therefore, the maximum dose is 3.9 cartridges for this kit. Topical anesthesia. Topical anesthetics to minimize the sensation of needle insertion and for very brief relief of pain, painful mucosal lesions. Their effectiveness is preventing the pain from injection. Not always has been demonstrated in studies, but they may be of value in many patients. Benzocaine is available in concentration up to 20%. Lidocaine is available as solution or ointment in concentration of 5% or spray of concentration of 10 10% or 15%.